Palliative care relieves suffering and improves quality of life for patients and families dealing with any type of life-threatening illness. Now, there are details to the definitions, but what I would like to highlight is that palliative care is for any age and for any serious illness. And palliative care can be provided alongside regular medical care. And it is not about the end of life, but about living. Looking at this beautiful illustration by WHO, this young boy is flying a kite alongside this gentleman. And we wonder who has the serious illness, or do both of them have it? Palliative care can be affordable for everyone in every country. However, looking at this illustration here, it is extremely saddening that the 9 shadows behind this lady does not have the opportunity to get their care needs met. So much so that the statistics show that 80% of the world's population lack access to pain relief. So will be coming from Malaysia, exploring service development in a few states of Malaysia. This is a country highlighted in yellow, and it's slightly below the equator line. And there are 2 bits to it, East Malaysia and West Malaysia. Now we know where Malaysia is on the global map. Where is Malaysia on the global palliative map? So in 2017, where mapping of the level of palliative care development was done, Malaysia was categorized in the isolated provision. So the darker colors are better and more advanced, and that is in contrast with the countries probably up here and down here. And in 2021, there was a measurement of quality of death and dying index. Now, I apologize for the small font. We can play a game on testing our eyesight and look for our country. And Malaysia ranks at number 62 and is being categorized as grade F. Now, we embrace this hard fact and we learn. Just 3 years prior to coming to that hard fact, a group of people put in tremendous amounts of effort to come up with this National Palliative Care Policy and Strategic Plan from 2019 to 2030, focusing on 3 key elements and 7 core strategies. Now, the first key element is equity, hoping to have universal health coverage to all people, ensuring their needs are recognized and have access, and hoping to develop a systematic network. The second element is sustainability, where education programs are key and community participation is encouraged. Third element is quality, where it's the hopes that standards of care can be established. And what are our palliative care needs? From this paper, where the estimation of 2014 to 2030, you can see that the palliative care needs are booming. In 2030, there will be a few states that have more than 25,000 people needing palliative care. And among the top 5 states that have the highest palliative needs in 2030 are Johor, Sarawak, and Kedah. And today, we have invited some of these speakers. Hospice Malaysia is hosting this webinar from Kuala Lumpur. And we invited Dr Ling from Johor Bahru, Dr Lim Liang Yik from Penang. And yes, these 2 bits on the map, small pieces, are Penang. Dr Sharon from Sarawak and Dr Fazlina from Kedah. So let's welcome our first speaker. Yeah, so Mei Ling is a palliative care physician in Hospital Sultanah Aminah, Johor Bahru. She's been running the service for 3 years, and she has been instrumental in developing palliative care in Johor Bahru, as she will illustrate in her following talk. So please welcome Mei Ling.
Yeah, hi everyone. Thanks for the kind introduction, and thanks to the organizer for giving me a chance to talk today. Yeah, as Win Lin said, I'll be going through a bit about the palliative care development from a Johor perspective. So just showing here a brief outline of my talk today, an overview of Johor, a bit on Johor's palliative needs, the challenges, and then a bit longer on the strategy to overcome these challenges. So this is Johor, and I think earlier on, Win Lin has showed as well on the map that Johor is the southernmost state in Malaysia, all the way down at the bottom, just above Singapore. It is the 5th largest state at 19,000 kilometers square. And just to put that into perspective, that means if you were to drive from the northern border all the way to Johor Bahru at the southern border, it would take about 3 hours. And in terms of population, it has the 2nd highest in Malaysia, just next to Selangor at about 4.1 million. And for myself, my first experience working in this state was about 11 years ago, where I was posted to Batu Pahat, which is a small district. If you see, that's the circle there in the map. And from my experience working there as a medical officer and general physician, what I saw then was that palliative care was generally not available in most places. So patients with palliative needs then had poorly managed symptoms. Generally, doctors were afraid to use opioids, didn't know how to use it, and so it doesn't get started. Patients with delirium end up being tied down, and most of the time, patients get isolated from the family even until the end of life. There were practically no discussion on end of life preference, no protocol for terminal discharge, or looking at end of life care at home. Even end of life care in the hospital was lacking. So that was then. And now fast forward to about 3 years ago, I completed my training in palliative care, and now I came back to Johor Bahru. Johor Bahru is the most densely populated district in Johor, and there's 2 hospitals here. The largest being Hospital Sultanah Aminah. This is the state hospital and main referral center, and this is where I'm based at the moment. The second tertiary hospital here would be Hospital Sultan Ismail, and this is where the oncology services is located. And looking at this, when I first came here, there were some non-specialist palliative care services now in Johor Bahru itself. For hospital palliative care services in Hospital Sultanah Aminah, it's mainly by the surgical department as part of their surgical oncology and palliative care unit. But they do have very limited service just for stage 4 cancer patient. And mostly the service is known to the surgical team. Other departments were not so aware and hence were not referring to them. And they have very limited medications as well, mainly just immediate release syrup morphine being available. Otherwise, there are no palliative care services in any of the other hospitals in Johor, including in Hospital Sultan Ismail, where the oncology services is based. And in terms of community palliative care services, it is by the NGO hospices, and this is available in Pontian and in Johor Bahru itself. So just 2 districts. All the other districts do not have community palliative care services. And while the services are so limited, but looking at the palliative care needs, as mentioned earlier by Win Lin, that Johor remained the top 3 states with highest palliative needs. Looking at this publication in 2022, the estimation from 2004 to 2014 show a case loads of 12 to 15,000. And projecting this into the future, into 2030, then we see an increase to more than 27,000 cases. And Johor remains the 3rd highest palliative care needs state in the country. And seeing that discrepancy in needs and services, the initial challenges include lack of awareness, because the services were just so limited that people have not heard of palliative care before, or there was a misconception about palliative care. Most people think that it's for end of life, something that is just for cancer patient. And there were even some who feel that palliative care intervention or medication could hasten death. And then, of course, there's the lack of access. People with palliative needs who need palliative care services could not access it, did not know where to look for it, and hence their symptoms were not addressed. Their psychosocial, spiritual issues were not addressed. And limited medication. So essentially, the only opioid available was syrup morphine, immediate release morphine. Other opiates were largely unavailable. And there was lack of training in using palliative care medication. So there were no allocation for it, no purchase of it, and nobody know how to use it. So I guess to overcome that challenges, the strategy can be summarized in one word, and that is engagement. And here I mean engagement at 3 levels: the decision makers, with our peers or collaborators, and with the general public. Decision makers here would be people with authority, like the hospital director, the head of departments, the head of pharmacies. So how do we engage with them? So with the decision makers, I'll say is the main process is through meetings, whether it's a formal meeting, for example, official head of unit meeting, in drug committee meetings, but more importantly in informal meeting, where we book a time to meet them, get 1 hour of their time when they are free, to really push the concept of palliative care, to explain to them what it is all about, what are the services offered, what is the impact of palliative care, to let them see the value of this service too, in terms of hospital costs, admission, the value to patient and to the family. And of course, we need to let them know what are the needs for the service provision. And this will include things like manpower, what kind of budget is needed, the allocation for medications, and so on, space, beds. And what we hope to achieve through this is to get a favorable policy change, in that we hope to get more manpower in the form of medical officers, nurses, budget and medication approval, so that we can get the medication needed for the patients, to get clinic slots, to get space, to get beds. So, and in terms of engaging with them, meeting them up, it does take some homework. For example, showing here is this table of a list of medications that I prepared beforehand, before going to meet with the hospital director, with the head of department, as well as the head of pharmacies, listing down what are the medications that I will need for the service, and including what's the cost like, an estimate of how many patients per year, and an estimate of the cost per year. And I would say that doing a table like this, doing all this homework, it just means that having the right connection was important. Like for doing this table, then it was helpful to be able to ask the palliative care pharmacists from the previous training center to get the cost, to get opinion on the estimate, and to come up with a figure. And it's also important to be realistically conservative in terms of the estimate, because we have to remember that resources is always limited. And when we ask for money, well, the higher we ask, the more we ask for, the less chance of approval. So by asking for something that's realistic, it is more likely to get an approval for it. So from this, I got 80% of what I asked for approved, and that was sufficient to at least get it started, to get some medications in, and then to add on subsequently. And in terms of getting clinic space, then by discussing with the medical department head, with the nephrology team, then we managed to start a renal supportive care clinic and got the space in the medical daycare to run this clinic. So even though there's no space in the usual clinic building, we can always tweak it, and we can look for other space to get it running. And just showing here, this is the QR code and flow that was shared to other all the nephro clinics in the state, so that it can help the nephrologists to refer to us when they see patients who require renal supportive care. Okay, moving on. Next is the engagement with peers and collaborators. Here we are talking about the other teams in the hospital, the healthcare staff, the doctors, nurses, collaborators like the NGOs, hospices, medical schools. I will say the main process of engagement with this group are through educational activities, whether it's like hospital level or department level CMEs, external events at state level, national level conferences, and as well as bedside teaching as well when we are seeing the patient. And at the same time, if the primary team who refer are there, the nurses are there, we can take that chance to teach them. Case discussion is important, whether it's during in-hospital referral, when the team refer, it's always good to ask, clarify what's their concern, what's the issue, and to give feedback after we have reviewed the patient. Same for external referrals when there are calls from the Klinik Kesihatan, from the other hospitals. And with the NGOs as well, so the nurses and the volunteers from the NGOs, when they visit patient at home, if they have any complex issues, I always welcome them to call me directly so that we can discuss management. And overall, through all these education activities, same, we hope to introduce the palliative care concept, so that people know what palliative care is about, and what services is offered, when is our clinic, what is the referral flow in terms of when, how, and who to refer. And generally is to encourage referral. I would say that if they're not sure whether patient should be referred, just refer. And of course, it's important to teach the basics as well, particularly through case discussion and bedside teaching, and to enhance patient management through all this discussion. So with that, we hope to increase access, increase referrals in a timely manner, and definitely have promote the palliative care approach so that everyone can practice palliative care at the primary level, and to empower the NGO so that they can do more when they visit patient. They can confidently increase their coverage to for non-cancer patients as well, and to increase the services that they are able to offer. So the first picture here is the first basic palliative care course that we organized in Hospital Sultanah Aminah. So for this, it was really to increase the awareness. We managed to get more than 90 participants for this course, where we sent out a letter to all the departments and asked them to send 1 or 2 participants per department. And it's free. So we managed to get a good turnout for it. The second picture here is a picture of NGO volunteers. They are from this NGO called Persatuan Kasih Sempurna, where they have been visiting patients at home, helping out at home, but they were keen to start helping patients admitted to Hospital Sultanah Aminah as well. So facilitating and getting them to meet up with the hospital welfare department, applying for approval to the pengarah. And here in this picture, they just received their official volunteer ID tag. So they're happily taking picture of that, and they just started their inpatient volunteer services last month. And just showing here some data. The first graph is the number of new referrals per year, and that's the total, divided to cancer and also non-cancer cases. But I first reported here at the end of 2021. So in 2021, that's the data for about 3 months. And you can see there's an increase from 92 to the following year, there were 570 new cases. And then in 2023, it was more than 1,000. But more significantly, we can see that as we encourage referral for non-cancer as well, as the previous services were only for cancer patients, you can see that the percentage changes, where initially it was 83% cancer and only 17% non-cancer. But by 2023, it was almost half, where 55% were cancer and 45% were non-cancer. While the graph on the right side, this is showing the number of outpatient reviews. So initially, again, it increased as well from initially 37 in 2021 up to 600 plus, as we increase our number of outpatient palliative care clinic to twice a week, as well as having the renal supportive care clinic twice a month. And next, we mentioned about engagement with the public, and this includes, of course, our patients, their caregivers, and the general public. So here is really through good care of our patients and caregivers to promote that positive experience, to let them know that what palliative care can do for them. And that will be our best advocate in terms of later on requesting it for other family members, for themselves, and recommending it to their other family and friends as well. And on a wider scale, then public awareness events to reach the general public who would otherwise have no contact with palliative care, hoping to increase awareness, increase knowledge, clear any misconception, change any wrong attitudes and beliefs. And overall, we hope to increase public acceptance as well as support. So one example of a public event would be this World Hospice and Palliative Care Day exhibition that we had last year at the polyclinic area of Hospital Sultanah Aminah. So we had staff as well as patients, the general public walking through and reading our the posters, getting flyers to find out more about what palliative care is about. The NGO hospices were involved as well, where they could explain about the services that they provide. So we are coming to the end. This is just a summary of what I went through. So when we recognize the palliative care needs and have the vision to improve access to palliative care, then moving on to the strategy process and outcome, the strategy will be engagement at the different level, And the process, as mentioned, through all the meetings, education activities, patient care, and with the outcome of policy changes, increasing access, promoting the palliative care approach, and public support. And in the end, we hope to achieve the value of reducing hospital admission and costs, a more goal concordant care, and better patient and family satisfaction. And all this while, all those is mostly focused on hospital-based palliative care. Moving forward, then there will be room to improve community palliative care through domiciliary palliative services, further empowering NGOs to increase coverage, increase services, education and training, including collaboration with universities for medical student training, and more advanced level training at hospital level, as well as at the community, NGO, and domiciliary level. And finally, research and audit for service evaluation and improvement. So this is my last slide. The take-home message here is that we need to engage to advance, engage at all levels, and what we want to do is to advance palliative care. Thank you.
Thank you, Mei Ling. It feels like a zero to hero kind of story, isn't it? Hard to imagine that just 3 years ago, there was hardly any palliative service on the ground, very minimal. I just like to, you mentioned timely referrals, Mei Ling. Well, we sort of know that earlier referrals than end of life is better, but why is it important? Wouldn't it be more straightforward for us to just be directly engaged with end of life cases, for example?
Yeah, thank you for the question and for the yeah. So to answer the question, I guess all of us will agree that palliative care is not just about the dying, it's about the living. And we really want to see the patients early so that we can focus on helping them live as best as possible, improving their quality of life. And also to catch that window period where we can do the discussion, we can help to focus on what I mentioned about goal concordant care, to be able to know what's important for them. So the early referral is important. Although end of life is of course very important as well for symptom management, early referral is just as important so that we can manage patient as a whole. And I think for a startup service with a lot of misconception for those people who have heard of palliative care before, tend to think that it is for end of life. Initially, I get a lot of referrals where patients were already hypotensive, having mandibular breathing and all that, where it's really too late to do anything except just physical symptom management. And I would say that with CMEs, with education activities, and just talking to the team who refer and telling them that, oh, you can actually refer earlier, we can definitely see an improvement where now people are referring much earlier. And we have the chance to do the discussion with the patient, to prepare the family, and to arrange in terms of preference for place of care, place for end of life, and things like that.
Thank you, Mei Ling. That's very helpful. Okay, we move on to our next presentation. Dr. Lim Liang Yik is a palliative care physician in Penang General Hospital, also since 3 years ago. He spent his final year of subspecialty training in Concord Repatriation General Hospital in Sydney, Australia. And Dr. Lim will share with us his experience in Penang.
Good afternoon to all. Thank you, Win Lin, for the very kind introduction. I'm Dr. Lim Liang Yik, a palliative care physician in Penang, and I truly appreciate the opportunity to share some ideas about opportunities to develop palliative care in Penang. I would also like to acknowledge that Penang has many leaders who have done great things in the development of palliative care, and many of the ideas I'm discussing today came from the palliative care community in Penang through formal and informal discussions. A brief introduction: Penang is a state in the northwest coast of peninsular Malaysia, and it consists of two parts, the Penang Island and the mainland, called Seberang Perai. It is an urbanized and densely populated state in Malaysia, with 1.8 million people occupying a space of about 1,000 square kilometers. Penang is rather unique in its journey to develop palliative care. It was among the first states in Malaysia to push forward with the hospice and palliative care movement. At the beginning, in the 1990s, this movement was largely powered by the community through non-governmental organizations, NGOs, adopting the not-for-profit approach. And when I speak to founders of this era, often adopting the belief that if the service is valuable to the community, the support and the funding will come. So Palliative Care in Penang in this era stood out for its NGO and community-driven approach. And these NGOs still stand today, they still stand tall today, and provide the bulk of out-of-hospital hospice services in Penang. Its leaders continue to play prominent roles in the development of palliative care. This spring of energy in the 1990s continues till today, where many institutions are joining the effort to create palliative care services. NGOs are volunteering to provide psychosocial support. Public hospitals, private hospitals, and university hospitals have developed consult and inpatient services, including in pediatric palliative care. Government clinics are also developing community services. There are also private nursing homes interested in developing capacity in palliative care, visiting local hospices to learn service models. All in all, while it started from the NGO platform, the government and the private sector and many institutions are increasing their presence. It is a multi-sectorial, multi-institutional approach. With all this energy, I would like to invite all of you now, let's look at how far Penang is in the development of palliative care. And for this, I agree with the actionable indicators by WHO to assess palliative care development in a region. To achieve the integration of palliative care into healthcare and to create a vibrant palliative care culture, we need all-rounded development in areas more than just services. We need policy and strategy. We need the availability of essential medications. We need services, education, advocacy, empowerment of the community, data, research, and also registry. Some of these, such as policies and strategies and medication access, we can rely on things at a national level and apply it to the local setting. At the same time, some areas like education, advocacy, empowerment, registry, data, we really need to consider the local context in development for us to be effective. So how are we doing in Penang? Let's take a look from the data and research perspective. A discussion on the development of palliative care, like what we are doing today, exposes one of the challenges Penang is facing. We do not have data providing information on trends and development as a whole to help us see the bird's eye perspective, which can guide service planning and engagement with policymakers and the public. Data such as a registry of all patients seen with details of site of care, duration under care, and end-of-life care site are lacking. These data are collected by the individual institutions. We are collecting them individually. But because palliative care institutions typically engage patients in one segment of care, the home, the clinic, the hospital, or the stay in hospice, when combined, these data get jumbled up quickly with overlap. The impact of this is, in today's sessions, perspectives are based on opinions and less so on data. Assessing how Penang is doing on the services front, it can be said that patients can access home-based hospice care, hospital care, stay-in hospice care, and outpatient palliative care clinics usually at a distance of about half an hour by driving on average. Crude estimations predicts that these services combined are seeing about 2,000 to 2,500 patients out of the 10 to 15,000 estimated palliative care needs that we have now. We do not have sufficient research to know how comfortable primary providers feel about providing care. On the education front, the local hospices have engaged with the local medical schools, RUMC, PMC, for decades, and it has produced among the highest number of graduates who pursue the palliative care specialist pathway in Malaysia. However, undergraduate nursing education remains an untapped territory. And feedback from palliative care and hospice administrators in the region suggests that there is a gap in the training of more advanced skills needed for full-time palliative care workers in the region. When new staff comes along, there is a lack of a structured learning platform, and importantly, a platform that allows the rotation of learners across hospice and palliative care institutions. This is to provide some understanding of what's happening on the other side, which is particularly important when institutions attend to a single site of care. We also have shortcomings in the training of basic palliative care skills. We also have shortcomings in the training of basic palliative care skills in primary providers. And this pool of providers is known to be very fluid, staying a place for a few months. Think of the trainees, the house officers. Currently, those interested may attend the occasional one-day workshop conducted annually with a capacity of 50 to 100 persons, or national level training programs at a combined capacity of 4 to 5 slots per year from the state. So it remains a challenge to quickly upskill people to be able to perform basic tasks like introducing palliative care, knowing how to access local services, and doing basic symptom control and communication. The question is, if in the same setting, the workplace can train almost all healthcare professionals with the ability to provide CPR and ACLS, can we replicate it in palliative care? On the advocacy front, much effort has been put into introducing services to the public and the importance of compassion, patient-centeredness, and home visits in healthcare, and we have harnessed strong community support. However, the observation is that the public accessing healthcare today in Penang, and also healthcare providers in Penang today, are not sufficiently aware of the issues surrounding shared decision-making, potentially inappropriate treatments in poor prognosis settings. And the distress is palpable, both from healthcare providers and receivers in clinical care as a consequence of this. Not surprisingly, WHO also sees this area of advocacy as an important pillar in the development of palliative care. So combining what I have spoke about the state of palliative care in Penang, the big picture, Penang has developed somewhat, the greens shown on this table over here, with plenty of opportunities for further improvement and the purpose on this table. And I believe these factors are very interrelated, where the further development of services is slowed by the lack of sufficient education platform to train the workforce, the lack of awareness on palliative care issues, and the lack of data to help us take that bird's eye view of what to do next. It is also interesting to note that it was the efforts by individual institutions with some collaboration with each other across the decades that have spurred our successes so far. in developing service in various sites and attachments to undergraduate schools. But if we want to think about the further development of palliative care in Penang, I feel that it requires us to work together as a team like never before. To take the example of developing training programs for more advanced skills for full-time providers. The university holds the platform for education. The government sector has the patient load for rotations. And the community hospices have the ground knowledge of what are the important skills. If you want to build a good program, it must combine the expertise of all these sectors and institutions. Another example would be the creation of a registry of patients to monitor trends. Again, it needs cross-collaboration between institutions to agree on a platform, a secretariat, and the information to collect. These are a few examples among many of how, if we want to develop further in Penang, we need conjoint efforts across institutions at the regional level. That is why we identified that a key step for developing palliative care in Penang would be the creation of a body that focuses on improving the local palliative care landscape as a whole. Specifically, this body allows individuals across institutions to work together on activities such as coordinating research and data collection, conducting educational activities, advocating palliative care issues, and creating collaboration. A body that keeps in its mind always the development of palliative care in the region, monitoring for areas of improvement using the bird's eye view. We launched a body called Persatuan Kerjasama Palliative Pulau Pinang, PKP3 we call it, in 2023 for this purpose. Membership is based on individuals, not institutional, and it accepts members from all backgrounds, not just healthcare providers. While still in its infancy, an immediate effect we observe is to fulfill the Registrar of Societies requirement of 4 times a year meeting. Several members of the palliative care community in Penang from various institutions started sitting down once every 3 months to think about the development of palliative care in Penang as a whole. One outcome of this is the Palliative Care Day in 2023, where institutions across Penang work together to organize a walk in the Penang Botanical Gardens. It is also in the process of organizing World Hospice and Palliative Care Day 2024 in collaboration with MHPCC and aims to focus on activities that highlight palliative care issues, such as advanced care planning, the experience of patients and carers through serious illness, or the plight of NGO hospices as a whole. Another outcome is an update of the common referral form that we have had for a decade in Penang, with centers in Penang on it, meant for clinician use, where the body tried to seek consensus as far as we can among institutions. We hope PKP3 can be useful in many other areas in the future. Among them, during our 3-monthly discussions, we heard the calls from the local community for a fellowship program focusing on practical training in more advanced skills for potential full-time palliative care providers, combining distance e-learning platforms and rotations through hospitals and community services. This can be a collaboration between the local university and PKP3. Many palliative care institutions in Penang are interested and want to be part of the planning process. We hope it takes off soon. I hope that the shared voice provided by this body can be used to tackle other issues in the future, such as primary palliative care provider education, the creation of a common registry, improving the presence of interdisciplinary teams, and engagement with local nursing homes. I wish I had the magic wand to wave and make things come true. These are likely decades in the making, but I hope that by the creation of the body, we ensure that there will always be a group of people in Penang who look at palliative care development in Penang as a whole in the future. So in short, for a place like Penang, where there are multiple centers providing services, each with its strengths and its ups and downs, there has to be a platform for collaboration so that at least there are persons taking the bird's eye view to ensure that in addition to providing services, we take small but persistent steps in reaching the common goal of fully integrating palliative care into the healthcare system, improving quality of life, and relieving suffering for patients with serious illness. Thank you very much.
Thank you, Liang Yik. It's very fascinating to see the contrast between the numerous palliative service providers in Penang. Very different from the situation in Johor with Ling. So could you share your thoughts on the advantages and challenges associated with having multiple palliative service providers in Penang?
Yeah, thank you, Lin. That's a very good question. I feel that it's always a blessing to have many institutions providing care, always a blessing. And I think that's how we can achieve access for almost all patients in Penang who needs palliative care. I suppose the greatest challenge is something that I highlighted in the talk just now, is when you have a lot of institutions, having a body or a person or a group of people that takes the bird's eye view to look at things as a whole and planning what are the next steps. Of course, these people should be spending a lot of time listening to the perspectives of all the stakeholders in the field. But we need that committee or that body or that group of people looking at things from the bird's eye view. I think that is one of the challenges that we are facing in this area.
Thank you, Liang Yik. We'll call upon our next speaker, Dr. Sharon Choo from Sarawak. Dr. Sharon Choo is our palliative care physician leading the service in Sarawak General Hospital. She has been there since 2021 and she has been spearheading development of service throughout Sarawak. And last year, she's also the recipient of the Cynthia Gold Fellowship program. And she's currently looking at building Sarawak to be a center of excellence. So please, Sharon.
Thank you very much, Win Lin, for the kind introduction. Good afternoon, everyone. So if we look at Sarawak, Sarawak is very much located in East Malaysia, as you can see on the map. And if you look, Sarawak encompasses nearly the entire of Peninsular Malaysia itself. It's a very wide geographical landscape with three major cities, which is Kuching in the southern region, Sibu in the central region, and in the northern region, we do have Niwi. If you look at the, this is a river view of Kuching city itself. Because of the vast geographical landscape, 60% of patients will be in the urban populations, while you see 40% of the population are in the rural sector. And my talk today will cover a few things, and firstly to highlight on the palliative care development roadmap, what are the needs in Sarawak, as we can hear from different ones, different opportunity, and why the team decided to focus on the two major opportunity of development and a personal reflection of this. So the palliative care was introduced into the Ministry of Health in 1995. And you will see that as palliative care continued to develop over the years with the introduction of advanced diploma in palliative care in 2014, only in 2016 that Sarawak General Hospital, which is a tertiary hospital and also the oncology center in Sarawak, introduce a small palliative care and some domiciliary services in the community via our NGO hospices. The palliative care majority were provided by oncologists, and they provide as best as they can together with NGO hospices. Only in 2021, there is an introduction of specialist palliative care. And in 2022, you can see that we started a pilot project on domiciliary palliative care in the health clinics. By 2023, this is rolled out all across the state in Sarawak. So our Malaysia policy and strategic plan aims to really integrate palliative care into all health systems. However, if you look at the current situation, many services, especially palliative care services, are only available in the urban setting in Sarawak, and literally is non-existent in rural areas. And why is that so? Look at the geographical landscape, and these are taken from different team members who showed me. People have to trek through jungles to reach a river, take a boat or a sampan, traditionally called in Sarawak, to reach the nearest healthcare facility, which may not even be the hospital. It may be just a small clinics. We have ongoing helicopters flying service. And sometimes when there's no accessible roads, we have to trek through dirt roads. And these are done through the different logging camps. So Young et al. In 2020 had projected that by 2030, with a population of slightly more than 3 million in Sarawak, we have 35,000 people who need palliative care. And out of the different states in Malaysia, Sarawak tops, and we are champion in the palliative care needs. If just have a look at the census in Sarawak General Hospital itself, even in 2021, there is about, just as the introduction of specialist palliative care unit, there's about 500 patients, but move forward in a short 2 years, there's in excess of 1,000 patients only in Sarawak General Hospital. This one does not include Mimi Hospital, Sibu Hospital, and all the other hospitals that have been able to provide palliative care services. And this is the map of the existing services in Sarawak 2 years ago. And you can see that many of these services are concentrated in the urban setting. And what we know is that from the data from our local hospice in Sarawak reported that 73% of patients, if they know that they are dying, they prefer to die at home. What does it mean is that it shows there's a big unmet needs where people want to be cared for at home, but there is no available service for them to be cared for comfortably in the home environment. And therefore, in Sarawak, we can summarize that we are in a very early stage of palliative care service. We know through the quality of death index, Malaysia stands at 62nd place, maybe even worse in Sarawak. And on the WHO Global Atlas of Palliative Care, we have very isolated palliative care provision, majority only in the urban setting. Therefore, we can see that there is a very strong need to develop palliative care, specifically in the community setting. So therefore, when we take a step back and look, what are the areas to focus in developing? We take a model of the Eisenhower box, is that we know there's urgency to develop palliative care, especially in the community, and what are the important areas that we need to cover, and that is the place that we need to focus and to do it. So the first thing that we focus is on palliative care advocacy in the state. And why is this so? If you take a look at the WHO booklet on the planning and implementation of palliative care services, to build a good community health service, the first number one itself is on advocacy to build support. It talks about sensitization, even of existing staff. And because of this, we need to look at what to advocate. Who do we advocate palliative care? Who do we engage with? It is very much who are the enablers of a successful palliative care service in the community to ensure there's ongoing communication, ongoing education, there is access to essential medications in the community, and there is also sustainable funding. So the decision then was for a top-down approach that we need to reach the highest, the people that are the policymakers, different ones. So our team start to reach out from a top-down approach, and we make sure that this is not done solely by the palliative care team of SGH. We engage in our ongoing champions, those people in the NGO hospices from Tu Chi Lodge Hospice, National Cancer Society. We meet with the Deputy Premier of Sarawak, and who is YB Professor Dato Amar, Dr. Sim Kui Hian. And why we choose to engage with him, first and foremost, after the Premier, he's the second most influential person in Sarawak. Secondly, he's a cardiologist, and he's the one that set the Cardiac Heart Center successfully to be in a global eye in Sarawak itself. And because of his pioneering spirit, he knows how to start things from the initial and what are the limitations, what are some challenges that the team will face, and engaging with him will garner a lot of support. The second person that we engage is the Sarawak State Health Director, and in the Health Director office itself, they are all the important people, including the Divisional Health Officer who manages all the health clinics. And if you want to look at a successful community palliative care service, we need to engage with the different stakeholders that will be enablers in this process. Thirdly, is that not to forget, we also need to continually engage with the different hospital directors to not forget that the hospital services need to continue to step up and be upskilled. So what we did is to continue to engage with our Sarawak General Hospital Director, Sibu Hospital, and Miri Hospital. We also engage with different departmental heads, different service leads, the nursing leads, and also the Dean of Faculty of Medicine, which is UNIMAS in Sarawak. So if you look at the photos here on the left itself, you can see that during the Asia Pacific Hospice Palliative Care Network committee, when they visited us for a scoping visit, we have an opportunity to engage and get our local hospices to be on board. We get the Sarawak State Health Department, the UNIMAS Dean, different representative of different voices and champions in palliative care to come together to speak to Prof. Sim on why coming together is important and why this is a good cause to support and to build in our state itself. On the right itself, when the American Society of Clinical Oncology that we are collaborating with visited Sarawak, we also similarly includes the different set of people. And this one you can see Prof. Sim is there chairing the meeting, and then we shared a PowerPoint presentation highlighting the gaps and the importance of service provision across the community in Sarawak. So I'm going to show you a video of Prof. Sim's support after these different meetings.
Even from the jungle of Borneo, the cancer and chronic disease burden is very high. Now, as Deputy Premier of Sarawak, I would like to bring palliative care services to all in Sarawak. Sarawak government is committed to develop it in a sustainable manner. We look forward to welcome all of you to Sarawak in 2025. Oh ha!
So Prof. Sim shared his support, verbal support. As Sarawak team goes on to bid for APHC, we wanted to host APHC for 2025. And he's further supported by the backing up of the Sarawak state government through the tourism, Sarawak Tourism Board. And you can see that he sent YB Datuk Wee, who is the Kuching South Mayor, to Korea itself to help with the promotional and boosting of APHC in 2025. The second person that we involved was this year, our newly appointed Sarawak State Health Director, Dr. Veronica Luga. And she has not heard about palliative care, and the advocacy starts even on the first month when she was appointed into the State Health Department. So this is in collaboration with our hospices. You can see CEO Hospice Tu Chi Lodge and also Dr. Lam himself coming together, championing the cause and raising up an awareness to Dr. Veronica. And shortly, within 2 weeks after that discussion and that meeting with her, she came with a letter of appointment to ensure there is good clinical governance in palliative care for the entire state. She gives the mandate for palliative care to be developed in a sustainable manner. This letter itself spoke about the finances, the resources, developing training and educational module, making sure there is ongoing quality improvement activity, research, and to develop KPIs within the stage. So After the first focus on advocacy, what then will the state want to look at? And the second one is we want to look at capacity building. And this is a very important aspect to ensure good and high quality palliative care in Sarawak itself. So when we look at the enablers, when we look at palliative care, we know that with education, essential medications will be the next one that will come in. But the education is the first step to ensure that all healthcare workers, whether in the hospital or especially the community, will be able to know how to provide. We started with our collaboration with the American Society of Clinical Oncology. It is a 12-week palliative care e-course. It was a very fun interactive session. And you can see on the photo here is that this is a graduation ceremony for people who have completed it. We have done and run this yearly now. And what we have noticed that every year as we run this, that this e-course, because it's it's a fully online session, is only good for participants with good internet connectivity, meaning that only participants only in the urban setting are able to engage. It still leaves a big question. What about the rural community? We still need to get palliative care training across for them. And we raised this up to our state health director in 2022 on these gaps. And therefore, in 2023, after a short pilot project, we established the domiciliary palliative care service across the entire Sarawak. We had the first workshop in Kuching itself, followed by the second workshop a few weeks later in Cebu, and a third workshop in Miri. And this workshop gathers all the primary healthcare specialists, which are mainly family medicine specialists, their entire team of senior MOs, medical assistant, their nurses, even pharmacists to be involved, to be trained in palliative care. So altogether, by 2023, there's 34 health clinics who are trained in domiciliary palliative care. And we can see that they have started the services, they have gotten the access to basic essential palliative care medicine, including morphine, different psychotropics across to all the primary care centers that are able to provide domiciliary care services. What we also notice is that because there is a high turnover of staff within these health clinics, we need to be able to train master's trainer to ensure a sustainability. So with the APHN visit, we come to a memorandum of understanding that was signed between the Sarawak state government with APHN, Dr. Ednin Hamzah, who's the chair of APHN, to start the Lian workshop for palliative care. And this is an intensive 5 days per session, and each mod we have all divided into 4 modules. And the aim is to train different master trainers across all 12 health divisions in Sarawak. So this is to ensure there's sustainability in the program that has been started. So all of these 12 healthcare teams that we selected, we specifically ensure that they are people that will not be transferred out very soon after the training. We try to get the family medicine specialists from every health clinics in each health divisions. There is a senior medical officer and also a nurse or medical assistant. And after 1 year, we have not planned for an audit, but we will. But what we can see is that what do these FMS and all these participants say? So this was published in the APHN newsletter last month. And one of it is Dr. C from Asajaya, who stated that she found that through the workshop, she had grown so much in terms of knowledge and managing palliative care patients with confidence. Dr. Adam from KK Song, and if you look at KK Song, he's very much in the Kapit division, in between Cebu and Kapit town. He stated that the teaching has enabled him to run a successful community palliative care service in Song. So what is the summary and reflection in developing palliative care in Sarawak? I think first and foremost is to sit down and think of what is the vision. What is the vision? What do the team envision palliative care will be in Sarawak? And to hold on to that vision, because every services must start with the aim in mind. Secondly, is that to recognize that there is a very steep learning curve to lead any services. You literally hit the ground running. There is a lot of skill sets to build within oneself. Advocacy will be one of them, teaching skills, mentoring, leadership skills, strategic planning skills, and collaborative skills. This doesn't come naturally for clinicians, but to continue to grow these skills, it's important to ensure that the service will be sustainable, the service will be impactful, and that there is ongoing improvement in the quality of palliative care across all platforms. Third one is to be able to prioritize, because there is a big competing interest between clinical work and non-clinical work. And you find that most people will, majority say 100% of their time are doing clinical work, but it's also important to mindfully set aside a small portion of 10 to 20% to do the advocacy work, to do the engagement, to do the training and education for capacity building. Lastly is that to know in developing palliative care is not to run it alone, because if you want to go far is to go together with a team, and knowing how to work and collaborate with various stakeholders is very important to ensure that sustainable and good quality palliative care services across Sarawak. So one of the future direction is to look into research, and that will help to inform the future policy, to inform on what are the gaps and the necessary resources that is needed to develop the services. Another future direction is to engage with our Sarawak State Health Director to set up a task force committee within the state to drive the policy, educational module as well for the entire healthcare professionals who are going to provide palliative care, to ensure that there is no dilution in the educational session. Thank you.
Thank you, Sharon. That was amazing. I think your state is so unique that the land of Sarawak is almost equivalent to the whole West Malaysia. Yeah. It's wonderful how you're mapping out Sarawak right from the start, statewide service, and you mentioned that you would like start hit the ground running. How do you, and I also hear many people who tell me how dedicated you are in clinical work. How do you prioritize all these competing interests, advocacy, clinical, leadership? How do you do it?
I think first and foremost is to begin with the end of mind. If to provide good palliative care, it's important to know who are the stakeholders, where is the service most important, and in Sarawak it is the community, and therefore not to work alone. We have ongoing hospices who have done excellent work in the community, and is to engage with them, to work alongside them to continue to develop the existing services and just channel it into a better service provision, because palliative care, domiciliary palliative care, although it's new, but domiciliary care in health clinics has existed. They have provided domiciliary service for stroke, for rehab. It's just to add on the extra layer of skills, finding the right personnel. That will be one way to help to upskill. And you will see that when people are doing it and they find there is so much satisfaction, they will want to be engaged. They will be the champions within their health division, and they will train the other health clinics. Importantly, I will say that the focus then will make sure there is ongoing teamwork. Delegation is important because you can't do everything on your own. So delegation, teaching the right skills, the leadership skill, teaching the mentoring skill to the other team members are equally important to ensure that there is no burnout and people are able to continue to multiply, and that the service will be sustainable across. Sorry, Win Lin, you're muted.
Dr. Chai Win
Thank you
Lin.
so much, Sharon. Yes. Yes, so we invite our next speaker and also our last speaker, Fazlina. So Fazlina is a palliative care physician in Kedah. She has been leading the service for 9 years. And Fazlina has a dream. She has a dream to integrate palliative care into primary health care. And working together with the community care partners, she is developing a project, and we'll hear about it. Thank you, Fazlina.
Thank you, Win Lin, for the kind introduction. Good afternoon, everyone. So today I'm going to share with you some of my perspective, especially on Kedah community care landscape, from my own lens as a palliative care clinician working in a hospital and also working closely with primary care partners. So the highlight for my sharing would be what would be the setup in Kedah and also the challenges and also opportunity. Some of it assisted through public policy and also national strategy, but I would like to stress how important it is to have a local collaboration and also to network with primary care. And a lot of things that I'm going to share with you, I'm going to latch on to what Sharon has said before. So just a bit of introduction. I'm sure by now you would know where Kedah is. So we are in the northern part of Peninsular Malaysia, bordering Thailand, and we are mainly an agricultural population, which means we rely a lot on farming and also fishing. Because of that, there's a lot of migration of the youth to Penang and also Johor for better job opportunities. And we are rapidly become the second oldest state for population age. So you could see there in 3 years, there is doubling numbers of the senior citizens. So the silver tsunami is hitting us hard. And as you heard before, Kedah is among the top 5 states with highest palliative care demands, and majority of the demand is actually in NCD, non-communicable diseases such as diabetes with end organ damage and organ failure, stroke with multimorbidity, end-stage heart failure, renal failure, COPD, and so on. So it's not just cancer needing palliative care. So because of that, silver tsunami and also the NCD wave, it is important to engage primary care physicians early and also to continue to network with them, because a lot of elderly and also a lot of people with NCDs are actually in the community, attending community clinics. And I just want to highlight 1 in 4 of adults in Kedah actually has raised blood sugars, and majority of them do not know that they are diabetics. So these also impact us hard in terms of, you know, having a caregiver for a person who's actually not well themselves. So it's sort of changed the landscape throughout the years, providing palliative care to the patients. So this is the usual journey of my patients in Kedah, and I'm sure in many parts of Malaysia as well. So I'd like to introduce you to Mrs. K, who has a breast lump. She went to her local primary care clinics and then was sent to tertiary center for further diagnosis and confirmation. So she had breast cancer, unfortunately, and she had her oncological treatment. So a lot of time in cancer care, so the patients would, the primary care or the main care of the patient would be in the tertiary hospital. And for Mrs. K, she would only go to the primary care clinic if she has diabetes, hypertension, or for or minor illness. So for Mrs. K, as the disease worsened, in a hospital providing cancer care, usually there will be a palliative care team or visiting palliative care clinic. So palliative care team would continue to provide care and refer to the community service when required. So for this presentation, I'm going to focus on domiciliary palliative care, and I actually put a short form on it as a DPC. So basically, DPC is a community-based program from primary care clinics that was initiated in 2014. So what DPC does is actually a local team from a local clinic that provide home visit and support the patient in the community. So the model of care is actually a shared care. So the DPC team would provide need surveillance, treatment of the symptoms, monitoring of the symptoms, caregiver support and training and rehabilitation wherever applicable. And for the case of Mrs. K, as she deteriorates, she enters end-of-life care. So the pathway would usually be to, not generalizing for everyone. So if the caregiver is able to cope with the DPC support and cope with the care, so they would continue to be at home. But let's say if the caregiver is unable to cope for the care, so sometimes it is necessary for them to be connected to the local hospital in order to continue to meet their needs. So death happens and bereavement follow-up will continue. So essentially when talking about community care in Kedah, so I would say Of course, a lot of people would want to die at home and want to receive home care as much as possible. But sometimes because of caregiver issues and multiple other issues, sometimes the concept of care closer to home also is equally important. For example, rather than sending the patient back to the tertiary center, developing a provincial hospital that has palliative care team also can help to support. The main thing is to have an ecosystem that can support each other, the domiciliary palliative care team and also the provincial hospital. So this is to illustrate the relationships between the healthcare facilities in Kedah. So Kedah is actually not very big. We house around, I think, 2.3 million population. Of course, it's never as big as Johor and also in Sarawak. But the challenges, we have the challenges of our own. So just to highlight with you, there are total 11 districts in Kedah, and each district has its own hospital. So in the red one, either the lead or major hospital. So this is where I work in Kota Star, the main state hospital, and also another lead hospital in Kuala Muda, Sungai Petani, and also in Kulim. So if you could see there, all these hospitals actually have feeders or actually have local clinics attached to them. So if you could see divided in colors, when the general domiciliary services were started in 2014, catering into rehabilitation for stroke and also traumatic brain injury. So a DPC team or palliative care team was included in 2018, and along the years, the number of teams has expanded and covering majority parts of the Kedah, providing increased access to palliative care. So I just want to share with you our own roadmap on how we develop services, especially community palliative care. So a bit of introduction again. Initially, the introduction of general domiciliary care was introduced to reduce prolonged hospital stay, mainly focusing on rehabilitation of patients with stroke and also traumatic brain injury to continue the care in community. In 2016, there is additional of domiciliary palliative care that piloted off in Selangor because it's a central region. And I came back to Kedah in 2015. And then after 2 years, the DPC program has been expanded to Kedah again as a pilot program. So at that time, we started off by training all the FMSs involved in the state. But again, I just want to stress at that time, there's no program guide as yet for the program managers because we are still sort of like troubleshooting what will be the best flow of referral, troubleshooting what are the issues in terms of resources, flow and everything, medication. So there's no guide for the program managers at that time. Another thing that I want to point out, even though there's a palliative care leaders at there, a lot of training because primary care at that time, they are not familiar with cancer care. So there are a lot of focus and also training actually focusing on the cancer care rather than general needs of palliative care. Because if you look at the roadmap of Mrs. K that I showed earlier, a lot of cancer care is actually in the tertiary care rather than primary care. And then in 2018, also because this concept is new, the program is new, people are trying to familiarize themselves on the concept of home visits and also providing care at home. So it takes a bit of a while for people to be really comfortable with it. So in 2019, the National Palliative Care Policy and Strategy was introduced. And then when we want to take things further, COVID comes and hit us bad. And because primary care is a public health resources, all the manpower are diverted towards the public health emergency. But one thing for sure, we know that after COVID, palliative care needs, especially in a non-cancer, is more visible. People started to realize that palliative care is not only for cancer, it has various other needs in a non-cancer condition, and also the availability of video conferencing platform, which I think is great because people start to get information and also education elsewhere and not restricted to a particular place. So it took 2 years for us to recover generally. So in late 2021, we realized that KKM or Ministry of Health released a short-term strategic plan, and one of it to enhance primary care delivery, especially in domiciliary care. So we take up that opportunity together with engagement of state health department, and I think it pushed a thing further when in 2022 the guide, the domiciliary and also DPC guide for program managers were published, and I think it solved a lot of issues because people now have something to refer to. And also not forget to mention, we have an opportunity to collaborate with Project ECHO. It's an online mentoring and educational session that utilizes the concept of low dose high frequency in order to further engage, especially palliative care teams in the community that already providing care. 2023, I think a lot of things happen, and I think this is the start of further engagement and also strengthening of collaboration. So I've mentioned that our primary care leaders in 2018 is Dr. Sri, and she is holding a very important position right now, and she is the lead for NCD in primary care, and together with Dr. Teh, so another person instrumental in the development of community palliative care in Kedah. She's actually subspecializing in palliative care, and I think it's just a good combination where we can take things further into this year, where we plan to have a local guidelines on early identification of palliative care needs in NCD, and also have a guide on how to manage these people. If I can turn back the time, so what are the things that I feel is useful for us to change? So now we are living in post-COVID-19 era. So a lot of people, especially primary care colleagues, are more familiar on the needs of palliative care, not only in cancer, but also among NCD's patients. So in order for you to provide training, especially if you're targeting development of domiciliary palliative care, I think it's equally important for you to get more examples from the NCDs or organ failures rather than focusing on cancer, because NCDs are something that is very familiar to primary care, and it's their bread and butter. They recognize the needs and they can actually relate to the needs closely. So I think that one I would stress, and the other one is how important it is to have primary care champion in order to push things further. So I wish I would engage primary care providers earlier, but I think we have a lot of challenges at that moment. So I think in the future, if you're planning to do local collaboration and also teaching, especially with primary care, I think it's important for you to identify the champion early. So the process outcome that we see from our domiciliary palliative care services, in Kedah average, we would have 3.6 home visits per patient, 75% achieve pain control less than 4, and 74% died at home. So we try to look at morphine utilization at clinic kesihatan or at the health clinic, but because a lot of morphine are actually sent over from the hospital, we find it's difficult to sort of like clean up the data to see how much is being prescribed, because there's always an overlapping data. So perhaps this is something that we could do to look at the development of domiciliary palliative care and also to see utilization and also access to morphine. So in terms of medication in Kedah, it is readily available, I would say. So in monitoring medication availability, I think it's not about morphine availability in a clinic, but more of morphine utilization. Because in a small clinic, let's say if they don't have morphine, they can easily access from a parent health clinics or also from the district hospitals. What are the challenges that I see in capacity building working with primary care? And I think we all know that because this is a public health resources, multitasking and also manpower is a huge issue. We have to remember when we engage the domiciliary palliative care team, the DPC is one of the community-based programs that they are running apart from other 30 or 40 other public health programs. So you must expect dilution in skills and also training. That's why one of the strategy that we are using is continuous engagement, either from local meetings or from using a teleconferences or video conferencing educational session. And I think we are very lucky in the sense that all areas of Kedah have good internet connection and they can easily log on and also learn more. The other thing is the challenges of shared care model. Domiciliary palliative care, even though they provide care, but after hours services is a challenge. So a lot of times, even though the patient is to DPC, after hours concern or support is usually by palliative care teams. So I think it's important to have a network or a system that speaks to each other or transferring the information smoother. So one of the challenges, of course, communication and also lack of clarities on roles. So the important solution that I find all these years is the importance of constantly communicating and networking. So I remember when I first started the domiciliary palliative care team, I actually or practically almost handing over via phone or texting all the family medicine specialists, handing over the patient case and also anticipation of symptoms and also symptom management guidance. And I think for me, it's particularly useful because I know their strength and I know their challenges. So it helps me sort of like to try to devise the best plan of care for the patient. And the other thing is, I think it's important to know everyone's strength opportunity because essentially we are working together. We are not competing with each other. So only by working together, understanding each other's limitation and also strength, we can only move further. The other thing that I realized that initially when we first started, there's a lot of gaps in care coordination. So one of the solutions that we did in Kedah is every year, the State Health Department will actually release a new list that is updated yearly or every 6 monthly on who's the clinical coordinator from each district. So it helps us to know who to call and who to connect to. I'm sure many of you are familiar with this palliative care roadmap published by Callaway in 2018. So if I can reflect my own experiences. So if you could see the first box there shows identify champion. If you're doing a business, the mantra is location, location, location. And if you ask me if you want to engage domiciliary care or you want to engage primary care, the first thing is to identify primary care champion, primary care champion, and primary care champion. So I can't actually say how important the champion is because this champion who's working on the ground will make things smoother for you in terms of medication delivery, availability, and also connecting with their own fellow colleagues, giving them confidence in terms of providing care. If you could see, there are a few colored boxes there. They are equally important for a nation to develop in order to expand their access to palliative care. But I'm going to touch on service deliveries and also education. I'm not going to talk about drug policy because in Kedah, drug is essentially available in many places. And I'm also not going to talk about financing because I think that is a really challenging part to talk to. If I could summarize my own recipe, our own recipe in Kedah, I think the approach of top-down or bottom-up is equally important. But if we need to choose one, I think having a system or policy to allow formal service delivery is the first thing that needs to be developed. Because you could train leaders, you could train people to provide care, but if there is no platform or system to provide service delivery, I think a lot of the training are going to be diluted quickly. So work on this first or engage important people to have some sort of platform to allow service delivery. And then I think engage continuously with your primary care leaders and champions. And again, continuous engagement is important because we know training dilution is going to happen. That's why engage, engage, and engage. And it's also very important to know each other's strengths and also weaknesses, respect each other and work together to achieve excellence. Last but not least, these are my take-home messages. If you ask me which one is important, both are important, top down and bottom up. But sustainability, I think, would be much dependent on bottom up because they are the one who's running the service. I've stressed enough, I think, the importance of networking and finding champion. Of course, the SWOT analysis, you need to figure out for your own area and also increase the awareness constantly with education. So before I end, I'd like to acknowledge Family Development of Division, Ministry of Health, also my dear Kedah State Health Department and also Primary Care Division, and all dedicated physicians, officers and staffs of TPC. Thank you.
Thank you, Fazlina. Both yours and Sharon's presentations are amazing because it's a buzzword to integrate palliative care into primary health care, and both of you are really keeping up with the global trend. I'd like to perhaps both Fazlina and Sharon can help with this question. Both of you are developing community palliative care, and you're using very different approaches. So Fazlina, you're using local governmental resources but working across sectors. And Sharon, you're using external resources, also working across sectors with our government primary healthcare. So could you both of you highlight the reasons behind your strategies and what are some of the resources you need moving forward?
Thank you very much, Win Lin. Is it okay, Fazlina, I address that question first? I think first and foremost, we need to look at that compared to Kedah, whereby the domiciliary palliative care service has been established since 2014, Sarawak is at the pioneering stage of the community palliative care, especially among the health clinics under the Ministry of Health. And because of that, we need to look at the existing resources to train healthcare workers in these health clinics. And you realize that with the existing resources, it may take longer to develop masters trainers across the state. But with a collaborative effort with other NGOs, whether is it through ESCO or is it through APHN, our Asia Pacific Hospice Palliative Care Network, I think it will speed up the training and educational progress in the state. And that is why, because there's such a strong urgent need for palliative care to be developed well ahead of 2030, whereby Sarawak will be projected to have the highest palliative care needs, we are at a race against time to develop a more sustainable and mature service. Because of that, and there is also a strong interest in the state health government to support this collaborative effort, it makes that it's just timely to bring and intersect all these different stakeholders together to develop the services.
Yeah. Thanks for the question, Win Lin, and thanks, Sharon, for the answer on your part. So I think we have to look at what are available resources and also what are the strengths and also the challenges in an area, for example. I think, Sharon, you are very lucky to have these external resources. I think many of us may not have that luxury or may not have that access. So I think it's important to identify the needs and look at what are the things that can help you in building up the capacity. Of course, educational resources. And it's not just having an external resource, having a standard for everyone to use as a teaching module. I think that will be great because having for example, educational module or existing resources that is available for people. So you could train someone or you could train an FMS. So the FMS can actually use that module to actually train others. So there needs to be a standard resources. I think that will be helpful to further, I think, expand the education and also capacity building further.
Yeah, so I mean, we have our national strategy to guide us, and probably this part of it maybe Fazlina and Ling would like to respond to this. And I think many countries develop national policy as well as the local policy to guide them, to cater for the local individual needs. And what are your thoughts on this? Fazlina and Ling.
Go ahead, Fazlina. You want to say something first?
Yeah. Sorry. Could you summarize your question again, Win Lin? Sorry, no, my
Yes.
connection is not very good. Yeah.
We have a national strategy, and do we need something else, a local strategy to further enhance service development?
Okay. So I think the national strategy is there as giving you a guide of overarching principle, but it is important for you to identify your own local scenario or situation, because all these principles are there for you to latch on. Development or local resources might be different. So trying to scout what are the opportunities that you have and latch on of each strategies, I think that would be something that you could do. So in order for you to do that, I mean, you have to have you have to know your people, you have to know who are your stakeholders, and you have to know how to network and work together. So it's important to knowing the resources and so latch onto the strategy.
Yeah, I think for me, I echo Fazlina's thoughts on this as well, where the national strategy is good as a general guide, but we do need to tailor it to the local setting. I guess for me, it's kind of like a recipe book. So a recipe book would give the ingredients, would give the general steps, but in the end, you need to know the local taste. You need to know who is going to eat the meal. So and of course, you need the cook to put it all together.
Can I say something on that?
Yes,
I feel that in relation to the national strategy, if you take the example of the community section in the national strategy, one of the key things that was said was in relation to a partnership between the private, the public, and also the NGO sector. But if you apply it to a local setting, that flavor of that partnership will be very different. For instance, like in Penang, where we have a strong NGO presence for many years, and the public sector, the health clinics are entering the field, providing the domiciliary service. Compared to another state whereby the health clinics are actually doing it more, and the NGO sectors are coming in to help out. If you look at these two situations, naturally you will see that the flavor of that partnership will be very different, while everybody is still coming under the national strategy. But how things actually unfold on the ground would be very different depending on the local sector.
Yes. Thank you, Yang Yik. You're talking about working across sectors, banking on that. We are working through NGOs, universities, government, non-governmental, and Sharon as well. You're getting external resources in helping develop palliative care from the tertiary hospital and the primary health care at the same time. May I ask the both of you, what is the scope of authority to navigate across these sectors as a palliative care physician in a tertiary hospital?
Is the question to me?
Yes, to Liang Yik and Sharon.
Oh, okay. Sorry. I didn't know.
Anyone
Yeah,
can chip in.
I think your question is about where does your authority stand, and when it comes to development of palliative care. I suppose if you look at the position that I'm in the government sector. I'm a palliative care physician in the hospital. So under that position, I think the area which I have more control on is actually the services within the hospital. But I feel that that is not how authority or how leadership works. I feel that it's not about the position, but it's about how you remain relevant to the people that you are working together. And when I say relevant, then it comes to really listening to the problems that the community as a whole is facing, able to estimate those many perspectives and come up with a plan that receives a lot of buy-in from a lot of people. So in that sense, I guess the position that I hold in the government service doesn't provide me with the authority. But that effort of trying to speak to people, understanding their problems, making sure that the plan that we come up with is palatable, acceptable to all. I think that is the one of the important strategy in extending our circle of influence.
I will continue from where Liang Yik left off. I feel that as a clinician coming from the hospital, developing services across hospitals are not hard because we know that the easy way to develop services in hospital, whether it is in Sarawak General Hospital or you talk to different district hospital or major hospital in Sarawak, such as Sibu or Miri, the challenge is that to develop successful palliative care program, people have to own the service. People must feel. So it's to really identify that we should not come in from a position of authority and sideline everyone, but to collaborate very close with various head of department, different parties to make sure that they own the service, that they feel that there is so much benefit in integrating palliative care into oncology or hematology or in medical or surgical services. With the health clinics and the community, similarly, because traditionally lots of NGO hospices has been the voices in the community, when you come as a figure of authority and sideline everyone, it doesn't work in that way. It is to work alongside and say that, look, we are going to support the service because where the stakeholders are, our patients' needs are, we can work together when we are stronger as one voice. So coming together to get them together to be part of the teaching faculty, to bring them together to work alongside. And at one point when our patient burden had increased for patient within Kuching to be enlisted to hospices, then we have to say, let's try to provide better access and support in the community. Let's focus on developing the community side so that the hospices are not overburdened with the care of patients. So I think working together and ensuring there's good relationship, that people own the service that they're providing, that the current FMSs that are leading the domiciliary service feel the ownership. I think that is very important for the satisfaction and the better outcome.
Gosh, you make it sound very easy, Sharon. and it sounds like, I mean, hearing all the presenters speaking, it sounds like you were all born to do this. I'm wondering about the skill sets that you all are presenting about today. How do you all develop these skill sets, and how would you advise someone younger like me to attain this skill set? And probably Sharon, you could just share from your side, and Mei Ling, you could add on after.
I think what has been really helpful is to have to be humble, to own up that we do not have all the knowledge and skills, firstly, and secondly, know where to seek for help once you identify those gaps. So for me, will be things like advocacy. I don't know how to start to engage with different stakeholders, and is to find a mentor, work alongside people who are familiar with this. And getting mentors, for example, like the CEO of Hospice Malaysia, Dr. Ednin, who's been mentoring me, making sure that I'm in the right track by getting different palliative care providers to invite them to your center, let them see the work that you're doing, encourage feedback to continually improve. I think that is really helpful because these people have so much experiences, they have done it, they have established different things. They have years of experience that they can share and probably impart token of wisdom along the way, and do not be afraid to be very upfront with your needs and with the service, what you need for service development, and to engage with different ones. I think that are some of the areas to start with before developing all the other aspects.
Yep. So adding on, I agree with Sharon that we have to be very approachable. I think, as I mentioned in my strategy, that it's important to engage, and to be able to engage with all levels, we have to be approachable to everyone, and so that people can ask us, and they feel ready to refer, and including with that's with our peers and with the NGOs as well, that even with volunteers, they find it easy to also discuss with us in terms of service development, in terms of patient management and all that, and overall to enhance patient management, to empower everyone, upscale everyone, and as Sharon said, not just ourselves, but to get everyone involved in this, because it's not something that we can do ourselves, but in fact, we need a whole team to fully develop the service. And I guess the second thing, I would say it's more of a character rather than a skill, is maybe resilience. I think as the other speakers all mentioned, that it is an uphill task trying to develop a service. And I think it's important to be resilient in the sense that there will always be shortfalls and there will be rejections, and there are times where we may feel isolated. So just being able to overcome that and to continue on, and to really have the support and connection with our other peers, our palliative care colleagues, to keep us going. I think that's very important wherever we are. Thanks.
Okay, I think as a closing remark, I think that's wonderful that each of you have volunteered to talk about your innovations and challenges and trying to overcome some of the needs for palliative care in each of your state. I really commend you on what you have done so far, and really what I feel has been most useful is each of your intervention has been through a personal innovation, that you have each looked at a situation analysis, strategized, and tried to think of a solution on your own. I think that makes each of you a leader in your own right. So that speaks well for the country. I'm hoping and assuming that similar advances are happening in each of the other states in the country. I think that moving forwards, I hope that we can develop strategies together. And I think that it has to be an integrative approach across all sectors and not just in MOH. One of the things I feel that hopefully we will see, maybe if we do this again, is to have nurse leaders coming up, because that's a key frontline of palliative care. And without strong nurse leaders, it's going to be incredibly difficult to develop palliative care. So I think it's been a wonderful session from all of you. We've had a lot of interest and interactions in the chat box as well. So thank you so much for your contributions today. All right, thank you so much.